Hey guys, you're watching the Best Practices Show, where we take a look at the best business practices from the best dental practices all across the country. And if you're finishing a day like this and you're working on high quality restorative patients, you know how difficult some of these days can be. And it's not easy. So I've got one of the masters on today, Dr. Bill Robbins, and we're going to be talking about the 9 treatment options for the most difficult patient. You do not want to miss this. Do me a favor, grab a pen and hit the share button. We'll see you in a few seconds. Hey guys, welcome back to the Best Practices Show. Thank you so much for watching. And this is one of my big days here. I get 2 of my heroes today. I got Dr. Bill Robbins. I had Dr. Rouse earlier. You know him well. So it's fun and just a great time we're having with these. And thank you guys so much for watching and sharing and all that. We're up to almost 20,000 followers on Facebook and over 50,000 on iTunes, which is insane. So I'm so grateful. A couple show notes. As you're watching this today, if you have questions, feel free to add them to the feed. And I'll ask Dr. Robbins to comment on them directly. Or if you're watching them later on, go ahead and add your questions to the feed, and we'll still get a good word from the man at the top. So I know this guy really well. Some of you know this guy. And if you don't know this guy, you got to know this guy. Dr. Bill Robbins, one of my favorite of all time. Now, I love you. So many people love you. But if somebody doesn't know who Dr. Bill Robbins is, give us a little intro on who you are.
Well, it's always a pleasure being with you, Kurt. You know, you're my favorite guy too, so I love being on this show. Thanks for the opportunity. I'm the oldest guy in the room. It didn't used to be that way, but now whenever I lecture, I'm almost always standing up in front, and I'm the oldest guy in the room, and it just happened in a blink of an eye. So I'm just a country boy from Arkansas. I ended up in San Antonio. I was an academic guy for 25 years, mostly running AGD programs, and I went to private practice about 20 years ago with my brother, Jeff Rouse, and Jeff and I practiced together for about 5 years and really grew up together in the teaching world. And then we split, and he went back, became a prosthodontist, and I left and built a building. And so we're still speaking partners. We'll still consider ourselves to be partners in the speaking and in the book that we wrote and such, but we don't practice together. So I'm a general dentist, practice in San Antonio. Have a great life. Great life, great family. Life is good.
Yes, you do. And I can speak about that firsthand. You are a very blessed man, and now a great associate in your practice. It's awesome. You're at a wonderful stage. Now, you and I were talking about this before you came on. I asked you, I go, how was your day? You go, today was a hard day. And I'm going to echo the sentiment I heard you say years ago. Maybe you can rephrase this. You said, you know, a lot of dentists say on Sunday, oh, I'm looking forward to Monday. And you said, I am not one of them. Can you clarify what that means? And today might be an example of that.
Yeah, this is a classic Monday for me. I do love doing dentistry, but Mondays have never been my favorite. And I don't sit around on Sunday night thinking about what I'm doing. But when I show up on Monday morning, commonly it's the hardest day of the week. And by the time I get through Monday and I get to Tuesday, I love being a dentist, and I'm happy at it again. So today was one of those days. I had a hard day in the trenches, and I'm glad to be done with it and here smiling and having fun with you.
Yeah, and we don't have to go through the details of the case, but you've taught me this. You love the predictability. You love when things come together. And every once in a while, things aren't so predictable. You know, they fall outside of that realm.
You want the story?
Go ahead. Go for it.
All right, so I had this patient that was referred to me 2.5 years ago from the Valley, which is down south of San Antonio. So it was a pretty good drive for this lady, and she'd had lots of hard dentistry done in her mouth, and much of it wasn't working out too well. And she needed orthodontic surgery. She needed mandibular advancement in the ortho, and she had implants were in the wrong place. It had to be removed, and it was one of those kind of cases. And she was a wonderful lady, and she was willing to do what we prescribed, and so she did the whole treatment plan. We went through the ortho, removed implants, orthodontic surgery, mandibular advancement, a wonderful outcome. She didn't have enough bone remaining in the maxilla for implants in areas that we had traditionally done. And so she was missing 7 and 10. And so we did 300 bridges from number 6 to 8 and number 9 to 11. And I inserted those bridges. Actually, I tried those bridges in about a month ago, and I didn't like the incisal edge contours. And so I sent them back, made some changes, and put them in about 2 weeks ago. Took my final photos, and I thought, man, this is one of those cases that I'm really proud to have been a part of. And I get a call from the orthodontist in the Valley today, and he said, I just saw our patient today, and she's got a 1 millimeter gap between her front teeth. She's got a diastema that's opened up with the bridges. And I said, well, they weren't there when I put them in. And he said, no, she said they weren't. But over the last week, they've opened up. And so everybody's thinking, okay, well, it's occlusion. And I'm sure it's occlusion, but she's not even coupled in the front. And the orthodontist couldn't find any excursion issues on it. So I'm going to cut those 6 units off and remake them somewhere along the line. And those were layered zirconia. So those of you who've done some zirconia and cut them off know what I'm up against. So among other good things that happened today, that was the one that was my classic Monday patient.
Yeah, never fun. But even the master is never perfect, right?
Well, that's for sure. Not that I'd fall into that category, but I proved it for sure today.
Yeah. Now I want to go into this. You and I talk about how great it is to be a dentist, and then the road ahead when you make a commitment to be a great restorative dentist. And you said the wear patient is often the most difficult patient in dentistry. Can you talk about why that is?
Well, the wear patient is so difficult because as the teeth wear, they commonly move into places that are untenable for us as restorative dentists to fix them. Mm-hmm. And through the years, we've struggled, first of all, trying to figure out why the wear occurred, and then secondly, how to restore these patients with a burr. And through the years, we've come to realize that generally these patients are more interdisciplinary, and commonly they can't just be fixed with a burr. And that's what makes them so difficult. And then, of course, the final part of it is once they're restored, we're worried that they're going to do the same thing to our dentistry that they did to their teeth in natural state. So they've always been the bane of the restorative dentist, and that is the wear patient and what to do with them.
Mm-hmm. Yeah. Now, if you're watching this for the first time, this is the first time you've seen Dr. Robbins on here, you got to go back and take a look at the other episodes because he's brilliant with how he categorizes some of the patients that come in and the options, and take us through a mini part of that journey before we go into the 9 options and what we've done before this.
Yeah, that's exactly right. So the systematic approach that my partner Jeff Rouse and I created over the last 20 years, it's called Global Diagnosis. And we believe that there are 4 global diagnoses that dictate all interdisciplinary treatment planning. The first is related to the upper lip, either short or hyperactive. The second is related to the teeth. And there's 3 reasons you can have short teeth. One is microdontia, one is incisal edge wear, and the third is altered passive eruption, which is gingival coverage the next of the teeth. The third global diagnosis is dentoalveolar extrusion. That's a fancy way of saying the wear patient. And that is the most difficult of the 4 global diagnoses to treat. And that's why I've spent the most time in the last 15 years thinking about that diagnosis. And that's where I've come up with these 9 treatment options for that patient. The 4th global diagnosis is a skeletal discrepancy, and that's obviously the patient that's either got a vertical component, vertical maxillary excess, or vertical maxillary deficiency. And then there's the AP components with the class 2 or class 3 malocclusion. So just briefly, that's the 4 global diagnoses that we use to diagnose any interdisciplinary treatment patient. But as I said, the most difficult one by far to treat is the dentoalveolar extrusion patient or the wear patient.
Yeah, absolutely. And as you can see, when we go through these, he's got an incredible system. If you haven't seen his courses, or now I do want you to talk about your book too, because I have a copy of your book, Global Diagnosis. Tell us what that is before we jump into this.
So Global Diagnosis is the system that Jeff Rouse and I created, as I said, over the last 20 years. And essentially, it built on the work of Coys and Spear. Coys and Spear get all the credit for facially generated diagnosis and figuring out where the incisal edges go in the patient's face. The thing that Jeff and I think, have added on top of the facially generated diagnosis concept that doesn't take the place of it, makes it better, is our emphasis on the gingival levels in the patient's face. And essentially, the global diagnoses tell you why the gingiva is in the wrong place. And so that's what the system is that Jeff and I have worked on. And we ultimately got a book finished about a year and a half ago on global diagnosis. So it's published by Quintessence, and it goes through all the global diagnoses we talked about. It tells the clinician how to make a global diagnosis on any patient by asking and answering 5 questions. It goes through the 6 tools that we have in our bag of tricks to fix any tooth gingiva interface problem. And then there's a big emphasis on the book on the wear patient, which is this dentoalveolar extrusion that we're going to talk about this evening.
Yeah. So let's go ahead and jump in and take us through all 9 options. The 9th isn't, we'll kind of save that as a secret for later.
Yeah.
But what's the first one? Take us right to the top.
All right. So the first one is no treatment. And it's not no treatment like we always know no treatment's an option. In other words, a patient can choose not to have any treatment. This is a little different. And this is for any tooth in the head, but it's primarily for one group of teeth, and that would be the significantly worn lower incisors. And traditionally, when I was doing my training many years ago, my prosthodontic mentor taught me that if I didn't have a good solution for a tooth, sometimes leaving it alone was the best solution. So back when we were doing full mouth rehabilitations back in the late 70s and early 80s, we really didn't have great solutions for worn lower incisors that had a significant amount of wear, because full coverage removes so much tooth structure that those teeth are in jeopardy down the road of fracturing. And so early on, reconstructions that I did were commonly 24 teeth rather than 28. And we'd restore 24 and leave the 4 lower incisors alone. So that is one option that I think still is legitimate today. If a patient chooses not to have orthodontic intrusion and have the teeth moved into the correct positions for us to do porcelain veneers on them and bring them back up to their normal incisal edge position with enamel bonded veneers, not dentin bonded veneers, then I still think no treatment is a legitimate option for the worn lower incisor. So that's the first one, no treatment.
Yeah.
The second one, go ahead.
No, you go.
The second one is reshaping opposing teeth. And I've mentioned Coys and Spears, 2 people that have had a giant impact on me. The third person that really impacted me a tremendous amount was Vince Kokich. And again, no surprise to anybody, he was the greatest teacher of the ortho restorative interface ever. And one of the things that I learned early on from Dr. Kokich was the concept of reshaping teeth that get in the way, and especially the super-erupted lower incisors. So we're back again to the specific subset of teeth that are so difficult to treat, and that's the lower incisors. And he had many cases where older patients would have upper teeth with significant wear anterior and lower teeth that are super-erupted. And one of his classic strategies was to reshape the lower teeth, in other words, shorten them, to make room to restore the upper teeth. And commonly today we do this with composite rather than with porcelain. So my second strategy, especially for the older patient, is the patient that has super-erupted and worn lower incisors that are super-erupted into concavities in the linguals of the upper anterior teeth, and we just shorten them. We just take a burr, turn it sideways, and shorten them. Essentially, patients at this age never have problem with sensitivity, and we bring the teeth back down to the correct occlusal plane, and then that gives us room to restore the lingual and incisal edges of the maxillary anterior teeth. So that's the second solution, and that is reshape the opposing teeth that are super erupted.
Go ahead. You want to just go through them and then we'll take them apart here?
Absolutely.
All
so
right.
the third is extraction of the extruded teeth. And one of my old prosthodontic mentors used to tell me, Robbins, don't let a tooth whip your butt. If a tooth gets in your way, one way to get it out of the way is to get rid of it. And this can happen anywhere in the head. You can certainly have a posterior tooth that's super erupted. But again, I'm talking primarily about that most difficult subset of teeth that are worn, and that's the worn lower incisors. And at some point, there's so much wear on the lower incisors that it makes no sense to do crown lengthening, functional crown lengthening, endo, posting cores, and full coverage. It just doesn't make sense. So it's a fairly common strategy in my practice today to take out 4 badly worn lower incisors, put in 2 implants, and place a 4-unit bridge along with whatever else we're doing in the case. So that's my third strategy, and actually one that I use every year, and that's extraction of the extruded teeth or the worn teeth, and commonly we're talking about the worn lower incisors.
Yeah. Now I want to ask you a question. Now you have all these wonderful methodologies. Are you using a decision tree for a lot of these? Because your worksheets are beautiful, like how you have them. Are you still using those today? The way you look at the 8 or 9 options here.
See, the cool thing about Jeff and my decision trees are that they're simple because they're all answered with a yes or no answer.
Okay.
So some people's decision trees start up at the top and they go, okay, so if you can feel the CJ, but the teeth is short and the lip is hit, and it gets so complicated, the decision trees are very difficult to lead you where you want to go. In our system, the decision trees are all yes and no answers. So yes goes in this pile and no goes in this pile. So it's the same way with these. With these 8 options.
Love it. So what's number 4?
Number 4 is a very traditional option that has a newer sort of classmate to go with it now. And the older option is the segmental osteotomy. So back in the old days, and I'm talking about 30 years ago at least, when a whole segment of teeth super erupted, it could be a posterior segment. So we could have lower molars extracted and the maxillary posterior teeth over time, the whole segment super erupted. So one strategy was to have the oral maxillofacial surgeon go in and do vertical cuts, horizontal cuts, take that segment and impact it and stabilize it. And once it was stabilized, then it was back up in its correct position. We did that in the posterior part of the mouth. We also did it in the anterior part of the mouth when segments super erupted. So that was a very traditional way, a very complicated but traditional way of dealing with a whole segment that super erupted. Today, the segmental osteotomy isn't done so much anymore, although it can be done. What's taken the place of the segmental osteotomy is surgically facilitated orthodontic treatment, which everybody's familiar with. That's where we couple a surgical procedure where the surgeon goes in and makes osteotomy cuts, which results in what's called a regional acceleratory phenomenon, which allows the teeth to move much more efficiently through the bone for 2 to 4 months after the surgical insult to the bone. So today, instead of being the primary surgical option being segmental osteotomy, today the primary surgical option I would say would be the surgically facilitated orthodontic treatment option, which commonly is not quite as aggressive as the segmental osteotomy. So I would say those two things go together in our systematic approach to dealing with this group of patients. Okay?
Absolutely.
The 5th option is a very specific, specialized option, and that's for the patient that has a significant centric relation maximum intercuspation slide. So a patient that has an anterior posterior CR-MI slide, sometimes they posture forward in the forward position of this slide, and they're end to end. And if that's occurring in a wear patient, you have no room to restore incisal edge length. In a given population of this group of patients, an equilibration can be accomplished, and the patient, once they're equilibrated, they're no longer in an end-end position. They've been equilibrated back to where their MI and CR are coincident, but they're coincident in a more posterior position, which now gives us room to restore incisal contour and length, which we didn't have when they were in the end-to-end position. Obviously, that has to be evaluated chair side, so the dentist has to have the skills to be able to manipulate a patient in a centric relation and determine if there's a big CR-MI discrepancy that's going to give us that restorative space. Then they've got to be able to get it onto the articulator, so you have to be able to mount the case with a face bow or a dental facial analyzer and some CR record. I use a leaf gauge as my primary way of getting a centric relation record. And then you go through the equilibration process on the cast to make sure that you have an endpoint for your equilibration and that you're going to end up with the room that you want. So again, it's a very specialized sort of situation for that group of patients that have significant CR-MI discrepancies, and the equilibration gives us room to lengthen incisal edges.
Yeah, can I ask you a question about equilibration? Because a lot of teachers they're using the phrase, and even Drew Cobb last week, he said it's kind of a lost art. It's something that we can certainly appreciate, but oftentimes, do you think it's going away a little bit, or is it? I'd love to know your thoughts on that.
Yeah, I do think it's going away. I think it's going away for a couple of reasons. Mm-hmm. One of the reasons, it's been one of those things, equilibration has been one of those things that's had an up and down I've been practicing 45 years, and so I've watched occlusion and equilibration go up and down through the years, and I think it's definitely in a down track now. The problem is that there's never been good data to support that an equilibration will stop a patient from grinding their teeth. Now, there's other things that equilibration certainly serve. We use equilibration in our practice after a patient comes out of orthodontic treatment routinely, and we use equilibration in our practice routinely in a patient that's got periodontal disease, because occlusal trauma in conjunction with plaque is a pretty bad recipe for a patient with periodontal disease. And the third group that we routinely equilibrate are those that we're getting ready to do large dentistry on, like full mouth rehabilitations. But the idea of removing CRMI discrepancies on most of our patients, I think, by and large, has gone away. Right. We're starting to believe that there's other reasons that people grind their teeth other than the fact that they may have a CRMI discrepancy, certainly airway being one of those major reasons. We've already talked to Jeff about that today.
Yeah, and the other thing, too, that it bears repeating, sometimes people, they equate equilibration with subtractive, but it can also include additive, which isn't a big conversation in dentistry either.
Oh, you're exactly right. In fact, equilibration is commonly additive, trying to get both canines back into a good relationship. Right. With equilibration, it's not unusual to get one of the canines into a good relationship, but not the other. And you have to ruin the posterior occlusion to get the second canine into a good relationship, or you can do additive, which is obviously what we do today. So I absolutely believe that there's a place for equilibration in a high-end restorative practice. The problem is it's a hard thing to learn, because where do you go to get it? I mean, there's just a handful of places on earth that you can go and learn to do an equilibration. And so it's certainly not being taught at dental schools anymore. And so, yes, I do believe it's becoming a lost art. I do.
It's still a great treatment option. Now, the next three are really the primary, would you say, when it comes to wear treatment? True?
Yes, absolutely. So what I've given, the first 5 options that I've given you are 5 fairly specialized circumstances, with the badly worn lower incisors or the super erupted lower incisors or the whole segment that's super erupted. So I'm talking about very sort of specific circumstances for specific patients. However, what I want the viewers tonight to take home, the one thing I want them to take home, is that there are 3 primary treatment options for the patient, for the wear patient, and that's the ones that we should be thinking about over and over and over again. The most difficult patients that are sitting on the viewer's desk right now almost always have dentoalveolar extrusion as one of the components, meaning it's a wear patient and the teeth have moved into the wrong place. Once you call it dentoalveolar extrusion, then these are the 3 things that I want you to think about, because over and over again, they're going to be the 3 primary treatment options. The first is restoration at an increased vertical dimension. The second is functional crown lengthening. And the third is orthodontic intrusion. So those are today our 3 primary treatment options for the generic wear patient. The generic patient with dentoalveolar extrusion are restore and increase vertical dimension, functional crown lengthening, and or orthodontic intrusion. And there are circumstances where more than one of these treatment options will be used. And I certainly have patients where we've used all 3 of these treatment options in restoring one patient. So why don't we start out with restoring an increased vertical dimension? Absolutely. That's a giant topic to talk about. And when I'm doing a course and talking about the 9 treatment options for dentoalveolar extrusion, I probably spend more time on vertical dimension and how to determine vertical dimension and how to get the vertical dimension from the articulator into the patient's mouth. The main point I want to leave is that certainly we're not about teaching how to increase vertical dimension today, but I do want everybody to understand that the idea about changing vertical dimension has changed in the last 40 years. All of the icons in dentistry for many years, up until about 30 years ago, taught that vertical dimension was a sacred position, a sacred spot that should not be messed with. And I think most of us that do this type of dentistry today have become very comfortable with the idea that vertical dimension within limits is certainly changeable. So I have very little concern today about altering a patient's vertical dimension. So where does it occur? Well, first of all, we have to figure out where the incisal edges go in space, and we have some guidelines to do that. Once you figure out where the incisal edges go in space, then somebody has to sit down with a waxing instrument and their computer with the photographs and do a diagnostic wax up. Now, obviously, that's changing. It's changing from real wax to digital wax, but it really isn't changing because whoever is putting the wax, whether it's real wax or digital wax, has to understand the principles that I'm talking about. And that's one of my concerns about the whole digital world, is that the tendency is for the restorative dentist to give up that part of dentistry that we used to have more control over, which is the diagnostic wax up. So certainly it can be well done digitally, but the restorative dentist has to be involved in it because the vertical dimension of occlusion is determined on the articulator in the laboratory. It is not determined in the patient's head. It's determined on the articulator. There are three components in my belief system about determining a new patient's vertical dimension. The first is anatomically correct teeth. So if you've got worn lower incisors and worn upper incisors, maybe you have lingual and incisal edge wear. The first criteria in the new vertical dimension is making anatomically correct teeth. So the upper and lower anterior teeth have to be anatomically correct. Second, they have to be coupled at a good interincisal angle, and that's going to be generally in the range of 100 to 135 degrees. And third, the anterior posterior occlusal plane must be level with no step up or step down. So the determinant of a patient's vertical dimension is this: anatomically correct anterior teeth coupled at a good interincisal angle with a good posterior anterior posterior occlusal plane. That's the determinants of the new vertical dimension, and that's determined in the laboratory. And then there are many ways to get from the laboratory into the mouth, and I tend to do it segmentally. I do my rehab segmentally. I do 8 uppers and 6 lowers as the first step. Once those are inserted, I do the upper and lower left posterior as my second step. And my third step, once those are inserted, is do the upper and lower right posteriors. But again, it can be arch against arch. It doesn't make any difference as long as the diagnostic wax up is done correctly and the patient has been set up correctly, commonly orthodontically, to do the reconstruction. It doesn't matter whether it's done arch against arch or it's done segmentally. It's got to be set up correctly. That's the issue. So restoring at an increased vertical dimension is a classic prosthodontic approach to treating the wear patient, and it's still one that we use commonly today. So that's one of the 3 primary treatment options. The second primary treatment option is functional crown lengthening, and it's the old-fashioned way. It's the one we've been doing the longest. And it's still legitimate today. It's legitimate in those patients whose teeth have worn so much that there's not enough clinical crown height in order to get the retention and resistance form we need for our final full coverage restorations. So functional crown lengthening is primarily for the wear patient who's lost so much tooth structure that we need more tooth structure exposed for retention and resistance form. So that's the second primary treatment option for the dentoalveolar extrusion wear patient. The third, and the one that I'm most enthused about, and I'm going to call it the new way, although it's not really new, orthodontists have been able to intrude teeth for us for decades. My oldest intrusion case is 25 years old now. But back in those days, we could only intrude anterior teeth. There wasn't enough anchorage to intrude premolars and molars. So the old cases are only intrusion of maxillary and mandibular anterior teeth. The beauty of it is today, now with TADs and skeletal anchorage, we can intrude anywhere from 1 to 14 teeth in an arch. And so within the last 10 years, the ability to place TADs and being able to intrude posterior teeth has totally changed the way we treatment plan the wear patient. So I have so much enthusiasm for orthodontics prior to restorative dentistry, primarily for 2 reasons. And this is my statement, and I think it's an important one. The primary purpose of adult orthodontics is to decrease the restorative compromise. And that occurs in 2 ways. First of all, I can commonly restore fewer teeth after orthodontics than if orthodontics wasn't accomplished. So that's the first big advantage for the patient. They can be restored with fewer teeth. The second big advantage is if the teeth are moved into the correct positions, the restorations can be more conservative. In other words, I can commonly do enamel-bonded restorations rather than dentin-bonded restorations, which have a much poorer prognosis. So the primary purpose of adult orthodontics is to decrease the restorative compromise, both in the number of teeth we have to restore and the amount of tooth structure we have to remove to place the restoration in the patient's mouth. So obviously, I have the most enthusiasm today for the orthodontic component of the 8 different ways of treating the dentoalveolar extrusion patient. But certainly the orthodontic component is not the only, and that's the reason you have to have the other 7 to go along with it. So what we've done, we've talked about the 5 specific specialized situations, and then we've talked about the 3 primary treatment options that we should be thinking in day in, day out. That would be restore and increase vertical dimension, functional crown lengthening, and orthodontic intrusion. So those are the 8 primary treatment options for the dentoalveolar extrusion wear patient.
Now, you're holding one card that you're saving to the end. That's really not a treatment option, but we include it anyway. And so can you explain what that means?
Okay, so here's the deal.
Okay.
I've been talking about dentoalveolar extrusion now for 15 years. And when I first created the lecture just on dentoalveolar extrusion, I only had 7 treatment options. Okay, only 7. Okay. And so as time went on, somebody came up to me and said, you know, I think this is a good idea. And I said, you know, I don't agree. I don't think that fits well into my categories, but here's my deal. If anybody can give me number 8, 9, or 10, I'll put an asterisk by your name and it'll be on my list. Well, nobody ever did that. And I came up with number 8 on my own. And so I came up with 1 through 8 on my own. And then obviously I fell in with Rouse and his airway business. And he was the one that said, you know, if you paid attention to airway when the child was young, then you wouldn't need all those other 8 things, because every one of those 8 things is related to airway, either in a small way or in a giant way. So 9 is prevention. And I'm talking about the airway issue, and I'm talking about in the child. I'm talking about in the young patient. And now I'm speaking for Jeff. If you have a child or a grandchild who grinds their teeth at night, who sleeps with their mouth open or snores, they have to be evaluated by a pediatric sleep physician, because those things are not normal. Children are not supposed to grind their teeth. And I shudder to think how many times I've told patients in my career, when parents ask, my children grind their teeth, is it normal? Yeah, it's normal. They'll outgrow it. I mean, I said that so many times, and now I know I'm going to be in purgatory for quite a long time, getting over all this bad information that I gave patients for all those 44 years. So if a child grinds their teeth, if they breathe through their mouth, or if they snore, there should be further evaluation, because none of those things are normal for children. And if we get this figured out when the child is young and get it treated, many of these 8 options that I've talked about never have to be pulled out of the bag of tricks, because they never developed the problems that had to be corrected. So in reality, I've got a great deal of enthusiasm about orthodontic intrusion. I've got more enthusiasm about preventing this from happening altogether.
Yeah. Well, one question that I always have to ask is, I always want to know everyone's thoughts on why, because we're seeing more, obviously there's more education now, you've got more data, but what's your hypothesis on, because everywhere we look now, we see airway issues. You know, I see them, I'm not even a dentist, and I'm like, oh my gosh, the kid's got bags underneath her eyes and she's 7. You know, and the mom's complaining she doesn't sleep, and they're thinking about putting her on medication. I'm like, oh, just get her evaluated. So what's your hypothesis on this trend?
Well, I think it's because you can't diagnose what you can't see, and you can't see what you don't know. And I know that's the case for me, and I think it's probably true for most of my colleagues. I believe that most dentists care. I've always believed that, and I still believe that. Most dentists care about their patients. And they haven't ignored these problems because they didn't care. They've ignored these problems because they didn't know. And I'm one of those people. I just didn't know. And because of people like Jeff and many others that have taken this whole ball and run with it and help open our eyes up to this whole issue of airway, I think it's an issue of education. And now we've come to realize that dentists are the perfect people to diagnose this. First of all, we spend more time with our patients than the physicians do. Secondly, we see the tracks of the problems in their mouth. We see the erosion that goes along with it. We see the bruxism and the wear that goes with it. We see all of the things, the big scallop tongues that go with this airway issue. And now finally we're the ones that can help the patients get to the right place to get diagnosed and get treated.
Right.
So it's a very exciting time. I mean, in some ways I feel more like a physician of the mouth than I ever have. Because we're finally talking about the systemic connection in a really specific way.
Right. Now, we got one more question, too, because the wear thing was so hot years ago. It continues to be hot. Tell us a little bit more about your thoughts about the trajectory of wear, because we could argue patients are going to live a lot longer now. 1 in 3 babies that's born today will actually live to be 100. So the art and science behind being a dentist, while it's so focused on treating the teeth, I mean, a lot of it is going to be figuring out these people are going to live for a very long time. No matter how wonderful of a dentist you are, you're still going to deal with forces and wear and all that. Tell us more, because you've seen a lot. What's the trajectory of wear look like in the future as a dentist?
Well, I think there's a reasonable chance that there's going to be medical treatments for caries and for periodontal disease. Mm-hmm. So I think the potential is there for those treatment needs to go away. Where I just don't see that happening. So I think worn and broken teeth are going to continue to be the mainstay of the restorative dentist for many, many years, even if caries decreases or is completely eliminated along with periodontal disease. So it isn't going to make any difference to me. I mean, by the time any of this is done, I'm going to be long gone. So I'll be finishing my career treating wear patients and broken teeth and caries and periodontal disease. I'll be doing all that. But I do think the potential is there for the young listeners to see a significant decrease in those two areas that are bread and butter right now in the restorative practice and the general dentistry practice. And I don't see the trajectory of wear decreasing until this whole issue of prevention is started, is given much more attention. And obviously it's going to take generations for that to get to the end user, which is going to be the 40, 50, 60-year-old patient that doesn't have wear on their teeth anymore. So I think the trajectory of wear is like this.
Yeah, absolutely. Any final considerations when you talk about the treatment options for the most difficult patient in dentistry? Any things you just say, hey, look, I'd summarize by saying this?
Well, the wear patient is a difficult patient to treat, and young dentists right out of dental school generally don't have the skills nor the confidence to do it, and I think that's appropriate. That's not the purpose of dental school. The purpose of dental school is not to learn to treat the wear patient or really any interdisciplinary patient, in my opinion. The purpose of dental school is to learn the skills to do single tooth dentistry, and then the young dentist is going to have to figure out some way of learning about this more sophisticated end of dentistry. And there's essentially 3 major ways to do it. One is to do a residency program, and I'm a great proponent of that, whether it be a specialty training or an AGD program. As a general dentist, I'm a great believer in AGD and GPR programs. So I think that's the best thing a young general dentist can do. The second thing they can do and must do is to join a study club or more than one study club. So that is the place where the younger dentist is going to be around older dentists that enjoy learning and enjoy mentoring. And that's the place where I think from a bang for your buck, you get the most bang for your buck. And that is by joining a good study club. Obviously, there's a bunch of Spear study clubs, there's a bunch of Seattle study clubs, and there's a bunch of independent study clubs around. So you should be able to find a study club in any moderate to larger size city that you can become a member of. And of course, the third way is to take continuing education. And I think that's the most difficult way to learn to do sophisticated dentistry. because it's the most expensive. You can't go to a state meeting and learn how to do a rehab in 1 day or 2 days. So in order to learn to do more sophisticated dentistry, you have to go to teaching centers where the masters teach. And it takes weekend after weekend and week after week and dollar after dollar to get there. So I think it's a wonderful thing to do. And clearly it was a very important part of my journey, taking continuing education from the masters. But I think doing an AGD, a GPR out of school is a really smart thing to do. And absolutely joining a study club is a key to moving from doing single tooth dentistry to interdisciplinary dentistry.
Buddy, that's why I appreciate you so much. And if you're a young dentist watching this, which we watch the metrics, there's a lot of kids in dental school watching this and younger dentists, please listen to that last couple minutes if you didn't hear anything before that, because that'll send you on the right journey to enjoy a great, great career in dentistry. Now, Bill, I know a lot of people are going to have questions. When it comes to your courses, can you tell us just a little, how do your courses work? How do I learn more about global diagnosis? Where do I start?
Well, the book is probably a great place to start, obviously. Everything is in the book, and it's simple, and it's well written, and it's not a real long book, and it's not very expensive. So I'd say that's a good place to start. Occasionally, Jeff will do a course, or I'll do a course. I have a course coming up in Austin, Texas, November 3rd and 4th, and December 1st and 2nd. So it's a 2-weekend, Friday, Saturday, November 3rd, 4th, and Friday, Saturday, December 1st and 2nd. And it's geared to the young dentist. And so if you have an interest in that, you can email me, robbinsdds@aol.com. You can call my office, 210-341-4409. Probably the easiest way is by email, and I can send you a brochure, and you can see what it's about and what it costs and all of that. So that's a couple of ways. The book, I think, is really helpful, and so happens I'm doing a weekend course coming up November, December in Austin. Austin's a great place.
Oh, it's an amazing place. And if you're watching this, you got a study club, you got to have the main man, Dr. Robbins, come out. He is a fantastic teacher. So I always learn great stuff from you, buddy. I'm so grateful that your wife lets us borrow you for a little bit in the days. So make sure you thank her. Stick around. Can you stay on just for a few minutes while we say goodbye to everybody else? But
yes, indeed.
I appreciate you, buddy.
Again, as always, Kirk, thanks so much. It's always so much fun being with you. You're the best.
Buddy. No, you're the best. Don't argue with me.
You're the best.
No, you're the best. And I always love your great words of wisdom. And I've said it so many times, but it's the Boy Scout philosophy. Our responsibility as leaders, people that care about the profession, is to leave the campfire in better condition than we found it. And you do that all the time. So thank you, my friend. Yeah. So, hey, if you're watching this, do me a favor, and you enjoyed today, hit the share button. We'd obviously love for you to share this information, protect this great profession that we love so much. Keep sending us suggestions for things that you want to see, not only from Dr. Robbins, from other people. We'll do our best to see if we can't get them on in a timely fashion. And until we see you next time, keep watching the Best Practice Show. You guys have a great evening. Thank you.